In the high-stakes world of emergency medicine, some tools are like scalpels, super precise. Others are more like sledgehammers. But what makes dopamine so fascinating is that depending on how you use it, it can actually be both. It's an incredibly powerful drug, but its effects are really nuanced. So today, we're going to break down how this one medication can do two completely different jobs. And it all comes down to one crucial factor: the dose. All right, so here's the game plan. We'll kick things off with the basics, what dopamine actually is. Then we'll dive into the real heart of the story, this tale of its two different doses. After that, we'll cover when it's a lifesaver, the risks you gotta watch out for, and finally, how it's actually used in practice today. So, first things first, what exactly are we talking about when we say dopamine in a hospital setting? Let's lay the groundwork. Okay, so dopamine, which you might also hear called by its brand name intratropin, belongs to a class of drugs called sympathomimetics. Now, that's just a fancy way of saying it mimics the effects of your sympathetic nervous system, your body's fight or flight response. It's basically a chemical cousin to epinephrine and norepinephrine, and it works by hitting those same adrenergic receptors. And this right here, this is exactly why it's so valuable in an emergency. It gets to work fast. We're talking 2 to 4 minutes. But its effects are also really short-lived, lasting only about 10 to 15 minutes. This gives clinicians incredible real-time control. They can tweak the dose up or down, and the patient's body responds almost immediately. It's not a long-term fix, it's a critical bridge during a crisis. All right, now we get to the core of it all. This is where dopamine gets really, really interesting, and it's the most important concept to grasp. See, this drug doesn't just do one thing. What it does completely changes based on how much of it you give. Probably the easiest way to wrap your head around this is to think of dopamine as a car with two very different gears. You can't be in both at the same time, and each gear is designed for a completely different kind of driving. So these two gears are what we call the cardiac dose and the vasopressor dose. At moderate doses, it acts one way, but when you ramp it up to higher doses, it acts in a completely different way, targeting different parts of the cardiovascular system to achieve totally different goals. Let's start with first gear. At a moderate dose of 5 to 10 micrograms per kilogram per minute, dopamine mainly hits beta receptors. The goal here is all about helping the heart. It increases the force of the heart's contractions, which makes it a much more efficient pump and boosts cardiac output. Think of it as giving a tired heart muscle the strength to squeeze harder. But when you push that dose higher into the 10 to 20 range, you shift into second gear, and this is where its effects on alpha receptors take over. Instead of focusing on the heart's pumping power, it causes vasoconstriction. It literally squeezes the blood vessels all over the body. So the goal isn't just to help the heart pump better, it's to dramatically crank up the patient's blood pressure. Okay, so with these two very different functions, when do clinicians actually reach for this tool? What are the specific, life-threatening situations where dopamine is the right call? Well, there are two main scenarios. First, for what's called hemodynamically significant hypotension. That just means a patient's blood pressure is so dangerously low that it's starting to affect their organs. But here's the crucial catch. This is only if the patient isn't low on fluids. You gotta fill the tank before you step on the gas. Second, it's an option for symptomatic bradycardia, a dangerously slow heart rate, but usually only after the first-line drug, atropine, has already been tried and hasn't worked. Of course, with any medication this powerful, knowing when not to use it is just as critical as knowing when to use it. And that brings us to the risks and the red flags you absolutely have to look out for. These right here, these are the absolute deal breakers. I mean, obviously, if a patient has an allergy, it's off the table. But more importantly, because dopamine can speed up the heart, you absolutely do not use it in patients who already have dangerously fast, irregular heart rhythms, what we call tachydysrhythmias, or if they're in VFib. And in a rare condition called pheochromocytoma, where a tumor is already pumping out adrenaline-like hormones, adding dopamine would be like pouring gasoline on a fire. And even when you use it correctly, there are potential side effects. You'll notice that the top two reactions are basically the drug doing its job a little too well, causing those fast heart rhythms or pushing blood pressure dangerously high. And by making the heart work harder, it also increases its need for oxygen, which can be a risk in itself. The other reactions, like headache and anxiety, well, that's that fight or flight stimulation kicking in. And remember, Dopamine doesn't work in a vacuum. It can interact with other common meds in some pretty big ways. For instance, if you mix it with an alkaline solution like sodium bicarbonate, you'll basically deactivate it. On the flip side, some antidepressants called MAOIs can make its effect dangerously strong. And it makes sense that beta blockers can blunt its effect, right? They block the very receptors dopamine needs to work on the heart. It's a complex chemical dance. Okay, let's bring this all into the real world. How is this drug actually given at the bedside in a way that's both safe and effective? With dopamine, precision is everything. First, it has to be infused through a large, stable IV line. If this stuff leaks out of the vein, a problem called extravasation, it can cause severe damage to the surrounding tissue. Second, it is always given using an infusion pump. You can't just let it drip in. The dose is so specific and so powerful that a pump is absolutely essential to get the flow rate exactly right. So the standard adult dose is that 5 to 20 micrograms per kilogram per minute range we've been talking about. But the key phrase here is titrate to patient response. This isn't a set it and forget it kind of medication. It means the dose is constantly being adjusted, a little up, a little down, based on what the patient's vital signs are doing. And when it's time to stop, you have to taper it off slowly to let the body readjust. You can't just slam on the brakes. There's also a really critical consideration for pregnant patients. In a life or death emergency, the number one priority is always to save the mother's life. So concerns about potential effects on the fetus do not prevent the use of life-saving drugs like dopamine for a critically ill mother. Now here's a really vital piece of modern context. For a long time, dopamine was a go-to drug for treating shock. But medical guidelines have evolved. Current evidence shows that for treating septic or cardiogenic shock, another vasopressor, norepinephrine, is now the preferred first-line choice. And that has definitely shifted dopamine's role in the hospital. And this really brings us to our final big question. If dopamine isn't the first choice for shock anymore, what is its place in medicine today? Well, it's still a powerful tool, no doubt, especially for certain types of slow heart rates, but its role has become much more specialized. It's a perfect example of how medicine is constantly learning and evolving, always refining its tools to get the best possible outcomes for patients.